come together. Before I get started, I have no financial disclosures. To give you an idea where I'm at University of Nebraska Med Center, or Nebraska Medicine. It's in Omaha, Nebraska. We have a beautiful and expanding campus. You can see the downtown's pretty nice. To give our international audience an idea where we are, basically smack dab in the middle of the United States, and we have a bit more going on than just being the home of Warren Buffett. So excited to speak to you on today's topic. So objectives for today. First thing, I want you guys to understand the role of cardiac MRI in monitoring for serial changes in LVEF, and going beyond that, and how we can use cardiac MRI to detect subclinical cardiotoxicity. Going from there, I want to teach you guys about using cardiac MRI as an imaging biomarker, and we do that by means of T1 and T2 imaging and LGE to some extent. So we'll be speaking a lot about that. And then finally, we'll talk about strain imaging, how it's used in both cardiac MRI and echo, and where there's some overlap between the two. And we'll have a couple cases in the midst of that and some checkpoint inhibitor stuff as well. So, all right, so to give us some context of where this all fits in the cardio-oncology, it's important to know that in cardio-oncology, we're looking at our cancer patients who are high risk for developing cardiotoxicity from their chemotherapy or already have pre-existing cardiac risk. We look at patients before cancer therapy, during cancer therapy, and after cancer therapy, different components to each of those stages. What we're going to be talking about most today is during cancer therapy and how we can use cardiac MRI to monitor for cardiotoxicity. So our ultimate goal as cardio-oncologists is for us to detect early cardiotoxicity and to treat it early as well. By doing this, we can hopefully reduce cardiovascular adverse events, and hopefully we can enable better treatment of the underlying cancer, mainly by avoiding dose interruptions or alterations in cancers in the chemotherapy. But on the flip side, we want to avoid excessive and overcautious management from a cardiac perspective. We don't want to make an inappropriate calculation that might lead to undertreatment of the cancer because you're concerned about their heart issues. And if you interrupt their chemotherapy, there's a chance that that could lead to decreased chance of remission and lower cancer survival rates. So that's why prudent and careful monitoring matters, and really an understanding of all our tools, because cardiotoxicity goes beyond just LVEF. We can have complications like myocarditis from checkpoint inhibitors, as well as arrhythmias, thrombotic events, ischemia, pericardial disease, valvular heart disease. So a lot of things that can happen that we need to be aware of, and cardiac MRI is a great tool that we can use to diagnose these potential complications. It's also important for us all to recognize that most of the research we have with cardiac MRI is done with anthracyclines and HER2 antagonists. There's obviously a bunch of other types of chemotherapy and treatments that can cause cardiotoxicity, and our number of treatments and continues to proliferate. So keeping up with these is challenging, and we also need dedicated studies for these new and emerging therapies as well. So in order for us to keep track of these, I think the start is understanding our full repertoire of ways to monitor and detect cardiotoxicity. Echocardiography is probably going to remain the mainstay, as well as using strain with echocardiography, just because of its easy accessibility and safety profile. Lab biomarkers, troponin is well validated as a great way to monitor for cardiotoxicity, both in anthracyclines as well as trastuzumab. ProBNP, there is some data behind that, but not as strong as for troponin. Cardiac MRI, here you can see cine here of a 4-chamber view. Cardiac MRI is very strong and accurate in measuring LVEF and doing tissue characterization. Nuclear imaging, you see a MUGA scan here, used more historically to calculate LVEF, not so much anymore, still done in a lot of centers, but cardiac MRI is definitely our gold standard for LVEF. And this figure here is from a great review article back in JACC Imaging in 2018. It shows all the things that cardiac MRI can evaluate in cardio-oncology patients. We can accurately quantify an LVEF. We can characterize the myocardium to determine the etiology of that drop in the LVEF. We do that by late gadolinium enhancement, T1, T2 mapping, and extracellular volume is also possible. We can also evaluate intracardiac mass. We can assess pericardial disease as well, complication of radiation therapy, and we can also assess valve function, which is another potential complication from radiation therapy. So cardiac MRI can be a one-stop shop for getting a lot of information about why our cancer patient is experiencing cardiotoxicity. But before we dive into those other things that cardiac MRI can evaluate, let's talk about ejection fraction, because LVEF is our principal marker of LV dysfunction. The accepted definition of chemotherapy-related cardiotoxicity is generally a drop in LVEF to at least 10% to a level less than 53%. That's our definition of cardiotoxicity. It's important to monitor for this and detect this because early asymptomatic declines are associated with subsequent progression to clinical heart failure and cancer treatment. So from there, echo is probably always going to be the first modality that's used to check an ejection fraction, mainly because it's low in cost, widely available, it's safe, there's no radiation exposure, and it's generally well tolerated by patients. Inherent disadvantages, though, LVEF is limited by geometric assumptions. The most common method we use to calculate ejection fraction is the Simpson biplane method of discs from a 4-chamber and 2-chamber. And while this is generally accurate, it is limited by geometric assumptions to calculate this. Echo is limited by the quality of the acoustic windows. If you have terrible windows or rib shadowing there, that's limiting our ultrasound beam. You're not going to get an accurate ejection fraction from that. And that's particularly a concern in our patient population with post-mastectomy patients because they have altered chest wall anatomy and can have very difficult windows. And also the test-retest variability in LVEF and non-contrast echo is up to 10%. So maybe not as accurate, but it is improved contrast in 3D echo. So when those tools are available, that is advantageous to use that. Other modalities for LVEF, we have our MUGA scans, historically used for LVEF, especially for anthracyclines back in the 1980s. It's good intra and inter-observer reproducibility because this is a very objective measurement of counts at end diastole and end systole. So from reader to reader, you're going to get accurate measurements, but generally it's considered not as accurate as our gold standard cardiac MRI to calculate an LVEF. Disadvantage to MUGA is radiation exposure, kind of a cumbersome exam for them to receive. And also we don't get much information for other cardiac structures. So you're giving them radiation and you're just getting an LVEF and maybe some other information based off their limited images. So they would probably be better suited getting a cardiac MRI in this situation because a cardiac MRI, superior reproducibility. This is a short axis cine stack. That's how we calculate our ejection fraction. We do contours at end diastole and end systole, and you can see here how that short axis goes through the long axis of the ventricle, and we're able to calculate an ejection fraction from the end diastolic volume and end systolic volume. And we always get pristine images, assuming the patient can hold their breath well, as seen in this short axis cine stacks, and we don't have any limitation from chest wall anatomy. So if you have a troublesome echo, then that's giving discrepant results from echo to echo, not getting an accurate ejection fraction. You really should refer them for a cardiac MRI to get an accurate ejection fraction. Cardiac MRI, again, no radiation, unlike a MUGA scan. And also to get an ejection fraction, to get these SSFP cine images, you don't need IV contrast for functional assessment at all. So you can get a lot of information just from a non-contrast study. But cardiac MRI is generally limited by access. It's not at every center, especially smaller hospitals may not have cardiac MRI. Length of study and the patients being claustrophobic and in the cardiac MRI for upwards of an hour, if it's a lengthy contrast study where you're doing a lot of sequences, that can be an issue for some patients. But we shouldn't think that every exam is going to be a burden to the patient because we can do a rapid CMR protocol. If we're just looking for an accurate ejection fraction and maybe a couple other non-contrast sequences. So you can do this in a shorter time than doing a complete echocardiogram and still get an accurate ejection fraction and also some basic information about other cardiac structures very quickly. Because we can get a lot of useful info without contrast. So keep that in mind in your patients that might be claustrophobic, or if they have end-stage renal disease and you're concerned about using gadolinium.
Jeremy, this is Dan Linehan from WashU. Thank you so much for your presentation so far. It's quite awesome, actually. But
thanks,
can you back a few slides to your MUGA example?
Yep.
And historically they even did prospective studies back in the 90s to show that LVEF by MUGA was better than echo. And I know those studies were done, and I think it probably is a more effective EF assessment than echo. But your example right here is beautiful. It's a perfect example in that, so you can still assign the edge detection on a MUGA, and so you can decide where the edges are, and just think about the interpreter variation just from doing that. I mean, there's your raw images on your figure, and you can see it's a fuzzogram. You can't really tell where anything is. And so you can assign the edges wherever you want to assign them. So I think that, the historical accuracy of LVEF by MUGA may be true when it's compared to an echo, but it really is, it's still very subjective. And if you leave it up to an automated program, then it's not going to factor in various technical issues. So I think that it's surprising how often MUGA is still ordered. And I will tell you a story, just, that you referenced the ASCO guidelines from 2017 on one of your previous slides. And I will tell you that, at the point that we had already completed the document and we were presenting it to the ASCO board, we presented it at the ASCO board when they were having their annual ASCO meeting. So there was like 15 people in a room, and this was even before COVID. So it was a webinar type or a teleconference type situation. So I wasn't actually there at the meeting, so I didn't see all the people, but there were 15 to 20 people in this room. They were all oncologists. And when we said in that document that we preferred echo over MUGA because of various reasons, the people in the room said, well, I don't understand why you even say that. I mean, we've been ordering MUGAs for years and I see no reason to change. So that was the chairman of the ASCO committee in 2017. So that, that whole historical precedent is firmly established. And, there are still lots of oncology areas that will order a MUGA instead of an MRI or even an echo.
Yeah, at the institution I trained at, actually, the oncologists often ordered MUGAs, and we were reading like 1 or 2 MUGAs a day, actually. But if a cardiologist was ordering it, generally it ended up being contrast echo. And I think that just a historical use and moving away from that would be fantastic, because now we have contrast enhanced echo, which is very accurate if you're able to see the heart well. So maybe with our updated guidelines, we'll have more clear recommendations. I mean, like the ASC guidelines, obviously they're gonna put echo first, but they do say echo, and then if you have discrepant reads, consider doing a MUGA versus a cardiac MRI. But like for all the reasons you said, I would argue that cardiac MRI should be your next option beyond echo. So.
Yeah, I mean, absolutely, for all the reasons that you laid out. But I mean, here's the maximum amount of information that you're going to get from a MUGA right here on this slide. So,
yep, for sure. Well, thanks, Dan.
thanks.
Gonna skip ahead here. Okay, so inherently though, we do have some limitations to just using LVEF to monitor for cardiotoxicity, because a lot of times when we do see that drop in ejection fraction, the damage may already be done. And sometimes in trastuzumab, of course, that might be reversible if you withhold the treatments or I'm on an ACE or beta blocker. But hopefully we'd be able to find a way to detect some clinical LV dysfunction. That way we can potentially implement cardioprotective treatment before you see that drop in ejection fraction, and then we can prevent interruptions in life-saving cancer therapies. And a way that's being evaluated to do this is using an imaging biomarker. So you know about lab biomarkers like troponin, BNP, but let's think of imaging biomarkers where we can detect subclinical cardiotoxicity. And cardiac MRI is a great tool, as potential to be a great imaging biomarker. And two things that our ideal imaging biomarkers should be is that one, it should detect toxicity prior to the development of myocardial mechanical dysfunction. And also, it should be able to interrogate the different treatment-specific pathophysiologic mechanisms of cardiotoxicity, whether that's myocardial fibrosis, inflammation, or ischemia. And cardiac MRI has ways to differentiate between those three things through the means of different sequences. We can use T2 imaging to look at edema and inflammation. Focal and diffuse fibrosis, we can look at focal fibrosis with our LGE images or delayed enhancement images. We can also use T1 mapping and T1 imaging to look for diffuse fibrosis. And also we have myocardial perfusion to look for ischemia. Accurate LVEF, we talked about this. Cardiac MRI is great at that. And also strain, we can get from an MRI, so not just echo. Here's a feature tracking strain sequence where they actually use a pre-existing cine sequence of a cardiac MRI and overlay the algorithm there, and it gives us a global longitudinal strain measurement. There's also strain encoded specific sequences that you can run strain on, so there's different ways to accomplish that, but we'll talk about that a little later. So let's talk about our potential imaging biomarkers within cardiac MRI. And so first of all, let's talk about late gadolinium enhancement, or LGE. For LGE, the way this works is that you give gadolinium or a gadolinium-based agent. Normal myocardium should wash this out within a few minutes, but when you acquire your T1 weighted images after about 8 to 10 minutes, then the fibrotic segments, or segments that have kind of basically stuff in the interstitial space that shouldn't be there, that's causing gadolinium to hang up, you'll see enhancement. And based on the pattern of enhancement, you can differentiate between different etiologies of cardiac disease. You can determine if it's ischemic or non-ischemic cardiomyopathy. In chemotherapy-related cardiotoxicity, we typically see a mid-myocardial stripe like this, often in the septum. That's not unique to chemotherapy-related cardiotoxicity. You can see that dilated cardiomyopathy as well, RV insertion point, the LGE as well. Also, in some studies, subepicardial LGE has been reported in doxorubicin-induced cardiotoxicity. So that's typically thought of as being related to myocarditis, but in the case of LGE, it can be seen in doxorubicin-induced cardiomyopathy as well. So there has been some animal models that have been done looking at using doxorubicin cardiotoxicity, or excuse me, using LGE to look for early doxorubicin cardiotoxicity before a drop in ejection fraction. This was a rat model. You can see small MRI image here that's very pixelated, so they can't really look for focal fibrosis, but they were able to take this region of interest, and then they get kind of an average gadolinium signal intensity measurement after doxorubicin exposure. They measured this sequentially and alongside an LVEF. And what they found is that if the rats developed an increased gadolinium signal. This predicted a later drop in ejection fraction. Also, this correlated with histopathologic evidence of vacuolization, which is typical of doxorubicin cardiotoxicity. So this animal study at least shows the potential for LGE or gadolinium enhancement as a means to predict for impending drops in LVEF from doxorubicin. However, this has not panned out in human studies. LGE is inconsistently present even after they've received their completed their treatment. It's reported anywhere between 0 and 30% in these retrospective studies. Also, none of these studies have been shown that the presence of LGE that has not been predictive of future decline in LVEF. Also, this has not been demonstrated to predict adverse cardiac events. So LGE may not be the right marker clinically right now to detect subclinical cardiotoxicity. And that's probably because when we are evaluating LGE in our cardiac MRIs, that largely represents focal damage or fibrosis that's already been done. We're not necessarily getting that average late gadolinium enhancement or average gadolinium enhancement signal like in that rat study. So this is focal fibrosis that we're evaluating. And anthracyclines are thought to cause diffuse interstitial fibrosis, like affecting the entire myocardium via excess collagen deposition, as opposed to this focal scar. So maybe LGE is not the right biomarker to use for detecting subclinical cardiotoxicity, but LGE still carries immense value as a diagnostic modality for cardiac dysfunction. It can help us accurately distinguish between ischemic, inflammatory, or an infiltrative process. It's very useful, for example, in cardiac amyloid, and it can help us even distinguish between ATTR amyloid versus AL amyloid. The pattern of LGE and ATTR amyloid, typically transmural, can get this pattern of gradient from base to apex. AL amyloid, you might see this diffuse subendocardial delayed enhancement here. But there is some overlap between the two, so it's not like a slam dunk diagnosis when you see each of these patterns. They're not necessarily 100% specific to that type of amyloid, but you can see that cardiac MRI can at least give you an idea of what you might be dealing with, and that can be helpful to the oncologist as well. So let's move away from LGE and talk about another potential for a biomarker for detecting subclinical cardiotoxicity. And that would, the next one would be T1 mapping. And T1 mapping, think of it as a native T1 relaxation time in our myocardium. All our tissues have a native relaxation time or normal range, but when you infiltrate your myocardium with something that shouldn't be there, whether that's edema or fibrosis, scar, amyloid deposition, that's going to make that native T1 relaxation time longer. And we can go beyond that and calculate a novel measurement called extracellular volume, where we take our pre-contrast T1 map, then we get gadolinium, then we get a post-contrast image, and then this equation using the patient's most recent hematocrit. We use this to calculate an extracellular volume, basically a volume of the heart tissue in the extracellular space. And this has actually been validated against biopsy proven specimens, so we know it's accurate. And this is very, very helpful, especially in our amyloid cases, but potentially has some value in evaluating for subclinical cardiotoxicity. We do know that breast cancer survivors do develop abnormalities in their T1 times and their extracellular volume. In this study, where they looked at 327 breast cancer survivors, they got an MRI after their treatment, so it was like around 3 years average after their time of diagnosis. And they found that the extracellular volume was elevated in the anthracycline group compared to the non-anthracycline treated group and the control group. Interestingly, in all the cancer survivors compared to the no cancer group, native T1 and ECV were elevated in those two populations compared to control. So we know that anthracyclines elevate ECV, but in general, cancer therapy for breast cancer seems to also impact native T1 relaxation times down the line. Another study, Better Care study, this was a prospective trial where they looked at low-risk CV, low cardiovascular risk breast cancer patients who are going to undergo anthracycline-based chemo. They got cardiac MRI and an echo pre-treatment, and then after they completed their treatment, on average it was 6 years after, they found that yes, down the line, there was a significant difference in T1 times in the cancer in the anthracycline receiving group versus the controls, but there was not a difference in ECV between the anthracycline treated group and the controls. And echo parameters like checking for their tissue Dopplers, longitudinal strain or radial strain, these were more likely to be different. Or more of these echo parameters were different compared to the MRI parameters. So echo parameters, at least in detecting anthracycline-induced cardiotoxicity or subclinical cardiotoxicity down the line, seem more useful. But the problem with these two studies is that we're checking for abnormalities in our T1 and ECV after their treatment. Our goal is to recognize abnormalities during treatment. And unfortunately, T1 abnormalities, ECV abnormalities have been inconsistently present in other studies. So definitely more work to be done with T1 and extracellular volume. I think there's still potential there. But comparing these, especially head-to-head with T2 weighted sequences, I think that we'll get some useful information. So let's move on to T2 weighted sequences. Think of T2 times as representative of the presence of edema or inflammation. When we see a higher T2 relaxation time, like here in the color map, the T2 color map, this blue area representing high T2 relaxation times, that's representative of edema. And then our T2 SIR image, which we can qualitatively evaluate for the presence of inflammation or edema, you can see the signal hyperintensity in the anterior septum extending into the anterior wall here. And that's representative of edema. And then here in the LGE images, you can see that this patient also has a typical pattern of myocarditis where they have subepicardial LG in that area as well. T2 abnormalities have been studied extensively in myocarditis, MI, Takotsubo cardiomyopathy. You can see it in intramyocardial hemorrhage as well. So we've seen a lot of information about T2 abnormalities, but can we use this as a way to predict chemotherapy-related cardiotoxicity or impending LV dysfunction? Well, this was a fantastic study that was published last year in JACC, where it was a pig model where they had 20 pigs and they used intracoronary doxorubicin. I think that's important to recognize this study was intracoronary doxorubicin, not systemic doxorubicin. And they have 4 treatment groups. And then each of these pigs, they did MRI evaluation of all these parameters, EF, T1 times, extracellular volume, T2 times, and LGE. The first group got 5 doses of doxorubicin and then sacrificed later at 16 and did a biopsy. Group 2 got 3 doses of doxorubicin and then sacrificed at the same time as group 1. Group 3 also got 3 doses of doxorubicin and sacrificed immediately after that. And what they found is that with the ejection fraction, all these pigs did have an average decline in their ejection fraction over time, but their T2 times were the only parameter that became abnormal before they had that drop in ejection fraction. Extracellular volume, which we derived from our T1 times, occurred a few weeks after you started seeing that drop in ejection fraction. So our extracellular volume was actually abnormal too late before you could probably have any clinical impact acting on that. But seeing the T2 abnormalities, it was predictive of the pigs that would later have a drop in their ejection fraction. What's also interesting is that in the group 2 pigs, where they got 3 doses of doxorubicin and no more after that, at 6 weeks after that 3rd dose of doxorubicin, you start to see some T2 abnormalities in their T2 color map here. But once you withhold the doxorubicin, that abnormality goes away. But if they got that 6th dose or the extra doses of doxorubicin, they continued to have T2 abnormalities at 16 weeks. They had abnormal T1 maps, and they developed this diffuse LGE pattern as well because they're injecting their LAD with doxorubicin. But this suggests that if you start to see T2 abnormalities and you withhold anthracycline at that time, you can see complete normalization of that edema inflammation there, and you can prevent the occurrence of LGE. So T2 abnormalities seem to occur at a time when you could potentially reverse the cardiotoxicity.
And so T2 reflects what specifically?
T2 mostly reflects edema or water within the myocardium.
And do most MRI machines have that capacity, or is it only if you have a specific software?
So all MRIs definitely have the capacity to check for T2 weighted sequences because most cardiac MRIs are going to be checking for T2 stir, but it's dependent on the vendor getting the software you need to do like the T2 and T1 color maps. That I think is an extra kind of thing you have to get from your vendor to actually have the capability of doing T1 and T2 color maps. But all cardiac MRI centers do have the availability to do T2 stir imaging, at least, where you can get a qualitative assessment of the presence of edema, but you may have to do a little more extra work and some post-processing with specific software to get the T2 color map. But you can still get a qualitative assessment, at least in all cardiac MRI centers of T2 abnormalities.
Well, so like, for example, echo strain, one of the biggest criticisms is, vendor specific data. And,
yep.
That could vary even within a singular institution. So an institution may have six total machines or 10 total machines, and 3 of them are GE and 3 are Philips and 3 are something else. And then,
yep.
So if your patient comes in and gets an echo with strain on a GE machine, and then the next time gets it on a Philips machine, are those two data points, valid? So at least EF should be relatively valid between those two measurements, but strain may not. So in the case of T2 mapping, are you going to have the same limitation?
That's a great question, and yes, you do have that same limitation. And actually, it's not just from vendor to vendor. It's from actual individual MRI scanner to MRI scanner. There is a difference in normal T1 and T2 quantitative values, a different normal range. So each center needs to determine their own lab's normal range because an T2 time at one center that might be normal at one center, it might be elevated in another center if you're using the same kind of range. So it is very similar to strain in that matter, but it goes beyond that you need to develop individual normal ranges for your institution. So it's not interchangeable between different institutions, and that's something definitely to keep in mind when we're like coordinating studies across different centers, that you might see some variation in our what our actual normal values are for T1 and T2 mapping.
Great, thank you for the answer.
Yeah, no problem. Thanks, Dan. So to sum up that study, T2 mapping provides earliest marker of anthracycline-induced cardiotoxicity. And also, when T2 mapping abnormalities occurred, it seemed to occur at reversible disease stage, because once they withheld the doxorubicin after the T2 abnormalities occurred, normal myocardium, whereas the group that received 6 doses of doxorubicin, their histopathology demonstrated extensive doxorubicin-induced cardiotoxicity. So in this case, the pigs were extremely helpful, very awesome study, great promise for what's coming in the future for T2 weighted sequences. But our real world experience so far has been mixed. Yes, we do see the presence of T2 abnormalities throughout patients' cancer treatment. This was one prospective study of 46 breast cancer patients receiving anthracyclines plus minus trastuzumab. They underwent a cardiac MRI at 1 month and then 4 months. And almost half of the patients by 4 months of their treatment had T2 abnormalities, showed edema on their images. But the presence of T2 abnormalities in this patient population was not predictive of those who would later develop LV dysfunction. So this is just one study, but which is maybe disappointing to some, but I think that pig study is definitely promising, and I think that we can build upon that and maybe do some more studies focusing on that. So I wouldn't give up on T2 weight sequences just yet. So let's bring it all together. What is the role of T1 mapping and ECV and T2 mapping for detecting early signs of cardiotoxicity? Well, clearly, we do see abnormalities in these parameters during cardiotoxic chemo and after they receive their chemotherapy. And in the case of T2 abnormalities, can occur before the onset of LV dysfunction. But we have limited clinical data right now. We need some human studies to validate using T2 abnormalities as a way to diagnose subclinical cardiotoxicity. And going from there, it'd be interesting to see if initiating cardioprotective meds like an ACE inhibitor or beta blocker at the first sign of T2 abnormalities, would that prevent LV dysfunction and prevent cardiac events, interruption of cancer treatment? So those are some clinical questions I have that could be answered in the future, but I think we just need a little more information about T2 abnormalities in our cardio-oncology population. So that's kind of wrapping up the biomarker section of the talk. I'm going to move on to using cardiac MRI and immune therapies. Definitely can't talk about cardiac MRI and cardio-oncology without mentioning checkpoint inhibitor myocarditis. That's because immune checkpoint inhibitor myocarditis, while it's uncommon, the course can be fulminant and potentially fatal. The case fatality rate of checkpoint inhibitor myocarditis has been reported anywhere between 30 and 50%. And outcomes are worse in this group compared to kind of run-of-the-mill myocarditis compared to checkpoint inhibitor myocarditis. So early diagnosis of this is crucial, and accurate diagnosis is also crucial. And cardiac MRI is a mainstay of our tools to diagnose checkpoint inhibitor myocarditis. This is a case study of a 47-year-old patient with metastatic melanoma. She was getting combo treatment with ipilimumab and nivolumab. She had a drop in ejection fraction of 25% on her echo, cardiac MRI, and that confirmed the reduced EF, had a LGE pattern that was diagnostic of myocarditis, has this diffuse subepicardial LGE. You can see it up here in the anterior septum, a little more faint, but definitely can't miss that in the inferior wall into the inferior septum here. Unfortunately, there was a delay in administration of high-dose IV steroids. The patient developed cardiogenic shock, and the patient passed. So this case illustrates that using cardiac MRI to do an early diagnosis and institute treatment early in these patients is crucial. And
Can I ask a question?
Yep.
So I agree about not letting us get too delayed in treatment. So how does treatment affect LGE in the first 2 or 3 or 5 days?
So actually, I don't know. I haven't seen a study that looked at that, seeing how LGE changes, or if they have abnormalities in their T2 times that quickly resolved after IV steroids. I'm not aware of a study that looks specifically at that, but I'd be happy to investigate and get back to you on that. But we do know that treating with the IV steroids aggressively does improve their course clinically, but from an academic standpoint, for sure, it'd be interesting to see to what extent the LGE resolves. We probably will see some fibrosis that hangs out after the fact, just because LGE, while it can be abnormal and represent edema in the tissue, diffuse edema, it can also represent fibrosis that's already there. So I don't think we'd see LGE completely resolved, but in myocarditis in general, we do see resolution of T2 abnormalities after they get their treatment or their disease process results, because that active inflammation is gone. So at least we can use MRI to distinguish between active inflammation versus non or no inflammation, and the LGE can tell us if there has been myocarditis present there or not. So does that answer your question?
So
Yes.
Joe, that's a very good question, but there was a study from, I believe it was from Germany, I want to say about a year and a half ago, looking at patients that were diagnosed with myocarditis, not in the checkpoint inhibitor era, not cardio-oncology patients, just typical cardiology patients that had suspected myocarditis. And when they did serial MRIs, a substantial number of them, and I feel like it was more than 70%, had no real change. And only a minority of those patients actually had any improvement after their initial diagnosis of myocarditis. So I think that what happens over time with these images is it's certainly not established in general for any kind of myocarditis, but it's really unknown for checkpoint inhibitor associated myocarditis.
Yeah, but I would be pretty surprised if within a couple of days of starting steroids that you would get resolution and it would not be as good diagnostically as it was before the steroids. So the major point is that we should never delay getting in there and treating to wait for an MRI, especially when there are pretty logical circumstantial evidence otherwise with troponin and EF is down, and it makes sense that that's the diagnosis.
No, absolutely, because the most important clinical event that you're going to do is high dose steroids in somebody with suspected ICI associated myocarditis, and the earlier you do that, the more effective it is. So that's been shown just from the paper by Dr. Mahmood and colleagues, that early high dose steroids had a better outcome. It doesn't have any comment about serial MRI imaging, but it's more about overall survival. So I think that you're right, absolutely, that the treatment of possible myocarditis is much more important than obtaining the MRI in a timely manner. I think it's more about if you're suspecting that condition, you need to treat for it, because the mortality is so high.
Right, I wholeheartedly agree with that. And also, you might not be able to get a cardiac MRI in the acute phase anyway, because if the patient is rapidly decompensating, they're very dyspneic, they can't even hold their breath to get the cardiac MRI, you might not even be able to get it in that acute phase anyway. So if everything adds up that it's clinically myocarditis from checkpoint inhibitor, I wholeheartedly agree that you should institute treatment rather than waiting. And then I'll kind of get to a little bit about the appearance of LGE. When you do have checkpoint inhibitor myocarditis, there's been a great recent paper by Dr. Zhang, and we'll talk about that in a second. But this is a case that I had a couple of weeks ago, or actually I was on vacation when this patient came, so I didn't get to see them personally, but this was here at the hospital. 64-year-old female with small cell lung cancer. She was receiving nivolumab, no prior cardiac history. She does have some pulmonary complications from her lung cancer, and she presented with shortness of breath. They checked the troponin as part of her evaluation. It was elevated and it peaked at 1.81. And her CRP was also markedly elevated at 4.8. And ECG was completely normal. She had no chest pain again. Got an echo. EF was reported at 50 to 55%. Also, they mentioned that there's wall motion abnormality of her mid to distal septum. They said, although to me the distal septum looks okay. Clinically, this looked like myocarditis. So she got a cardiac MRI. She was stable at the time, so didn't get IV steroids immediately. So they felt they had time to get a cardiac MRI. The delayed enhancement images, while these are kind of fuzzy, not as pristine as you might see in a beautiful case report, but overall, there's no LGE. Everything looks black and normal throughout the myocardium. So delayed enhancement imaging was unremarkable in this case. But it's not just about LGE for evaluating for checkpoint inhibitor myocarditis. We have to use our other MRI parameters. In our updated Lake Lewis criteria from 2018, we have to look at also T2 weighted imaging, whether that's a T2 color map here and quantitatively assessing that, or looking for T2 stir abnormalities and assessing that qualitatively. T1 mapping is also key to quantify the extent of non-ischemic myocardial injury. We can use T1 mapping or ECV too, and then the presence of LGE also can be suggestive of myocarditis. So in this patient, there was no LGE, and then this is T2 stir imaging. Again, this is a sequence looking at, looking qualitatively at the presence of edema. So we're looking for signal hyperintensity, and this is a short axis stat going through maybe down there in the inferior septum, maybe some hyperintensity, but overall, this was just kind of non-specific. And usually in really obvious myocarditis, you get really bright hyperintensity to the extent of this fluid down here. So in this case, the T2 stir imaging was not diagnostic of myocarditis from the checkpoint inhibitor. But that's why we took it a step further, or the docs at the time took it a step further and did a T1 map. And here, diffusely elevated T1 times all throughout the myocardium. This patient, our normal value, our upper limit of normal is 1100 milliseconds. And you can see in the 1200s throughout here, 1300s down in the basal inferior wall. And that's where we did see maybe some qualitative enhancement or qualitative signal and hyperintensity on the T2 stir imaging. T2 color map as well showed elevated T2 times. And here was some region of interest quantifying the T2 relaxation times here in the inferior septum, 78 almost milliseconds for T2 time. So that's definitely abnormal. So quantitatively, this patient had really significant markers of myocardial injury and myocardial inflammation. So based on this, the patient was treated with IV solumedrol, had clinical improvement in her symptoms, and she was discharged with prednisone taper. We saw, since this was recent, we're still waiting for a follow-up echo. I think at least academically it might be interesting to get a cardiac MRI just to see how these changes evolved, or maybe she did develop LGE later on. But this case really fits into this paper that was just published by Dr. Zhang in the European Heart Journal, where they had a large population of patients, 103 that had immune checkpoint inhibitor myocarditis, and they all underwent a cardiac MRI. And all these patients did get on their MRI LGE evaluation and T2 stir evaluation. Only like 30 patients also got T1 mapping, and less than 10, I think, got extracellular volume calculation. So that the quantitative measurements of T1 and T2 abnormalities was not present in every single patient, but at least they were definitively able to show that the presence of LGE and T2 stir are present sometimes, but sometimes they're not present at all. And in this group with patients with less than 50% ejection fraction, 40% of those had no LGE and no T2 stir abnormalities, but they clinically had checkpoint inhibitor myocarditis, and some even had biopsy-proven myocarditis, and they were treated appropriately for that. So important to know that we can't just rely on LGE and qualitative T2 stir analysis. I really think in these patients, you have to go a step beyond and use quantitative T1 and T2 mapping, because that can be extremely helpful and complementary to our classic evaluation of just looking at delayed enhancement for myocarditis. Also interesting is the time of the MRI really impacted whether you're going to see LGE in the first place. So if the MRI was performed within 4 days, The patients that had myocarditis, the majority had no LGE, 78%. But if you perform the MRI later after their time of presentation, at least 4 days after, the majority had the presence of LGE. So LGE might not show up acutely, and it might take some time to develop. And so you really should not rely on the absence of LGE. That shouldn't be reassuring to you if the patient still clinically looks like myocarditis. And this emphasizes that you need to look at all your MRI parameters, including T1 and T2 mapping and T2 stir imaging for a complete myocarditis evaluation.
So,
and
Jeremy,
go ahead.
Answered the question that it doesn't matter in a couple of days. My original question about, I think that answers the question, right?
Yeah, definitely. So if you don't see LGE in that initial MRI, it's still, if you clinically suspect myocarditis, you should still treat it as such. But definitely looking at our other parameters will be helpful, and at least confirming the diagnosis or suggesting the diagnosis. But again, clinically, if it's suggesting myocarditis, you should not delay treatment, because then you just be causing harm by delaying treatment. And also the authors concluded that presence of LGE or an increase in T2 stir signal, they were not associated with major adverse cardiac events. Also, the rate of LGE and T2 stir abnormalities compared to regular kind of run-of-the-mill myocarditis, this was far lower than those, which makes it even more tricky to treat or to diagnose immune checkpoint inhibitor myocarditis, because this is kind of wonky and is not presenting how you would expect on an MRI, just like our regular viral myocarditis. And just the key takeaway, I think, from this is that the absence of LGE or T2 stir signal does not exclude the diagnosis of checkpoint inhibitor myocarditis. So if you have clinical suspicion, treat it as such. And because ultimately, even in patients with the normal cardiac MRI, they can still biopsy proven checkpoint inhibitor myocarditis. Stephen, how are we doing on time?
You got about 5 minutes.
5 minutes. It's okay. So, all right, I'm going to skip over this case here. This was, well, briefly, I'll just say that this was a patient that had suspected doxorubicin cardiotoxicity, drop in their ejection fraction, but ended up getting a cardiac MRI, very abnormal stress perfusion. I think it's interesting for you guys to see this. Subendocardial perfusion abnormality, representing ischemia all throughout the inferior septum, all the way out to the anterior lateral wall, from the base down to the apex. And so this patient ended up not just having doxorubicin cardiotoxicity, or they did not have just non-ischemic cardiomyopathy, they had ischemic cardiomyopathy. LGU was characteristic of that. And patient underwent cath and ended up with a bypass and had improvement of their EF from 25% to 50%. So quick lesson, don't always assume that cardiotoxicity is from chemotherapy. If you have a patient that comes to you with a new reduced EF, and even if their echo looks like global LV dysfunction, you must exclude other etiologies, and MRI can be really helpful in that, in determining if this is non-ischemic cardiomyopathy versus ischemic, or if it's mixed etiologies in a single study. Some other applications of cardio-oncology and MRI, look at constricted pericarditis. Again, like I mentioned before, amyloid. Here, this is an example of a look locker sequence used to set up our LGE images. And in this case, the myocardium's nulling, or excuse me, becoming bright and takes up contrast before the blood pool. And that's pretty suggestive of cardiac amyloid. We can use it to evaluate cardiac masses and tumors. Weren't able to talk about that today. Iron overload, also important in our patients receiving lots of blood transfusions, and we use that T2 star sequence to evaluate that. Also, we can use it to evaluate for Takotsubo cardiomyopathy in our critically ill oncology patients, and assess our valve patients. We already kind of talked about strain, so I'm not going to dive too much into that. Basically, just remember in echo strain, there are a lot of vendors with different strain software. there is a lot of inter-vendor and inter-software variability. So keep that in mind that you're comparing apples to oranges when you're looking at two different strain measurements from two different types of software. Also, the limitation of 2D echo strain is that you require good images to actually calculate that strain. Cardiac MRI overcomes this by the reasons why, same as before, why we're able to get a better ejection fraction from an MRI compared to an echo is because we're avoiding the limitations of chest wall anatomy and impacting our image quality. You can do this by feature tracking over our existing SIMNI sequences, or you can use strain encoded sequences as well. But feature tracking tends to be a little easier because you don't have to do an additional sequence. We currently lack the same large-scale studies dedicated to CMR, like what is done with echo strain, but you can think about cardiac MRI as being comparable to echo derived strain, but the values are not necessarily interchangeable for the same reason that there's lots of variability between vendors. There's definitely going to be differences between modalities. So keep that in mind that you can't directly compare strain measurements necessarily. And this kind of goes back to echo, but contrast enhanced strain is something that's coming up as well. Echo Insight is the only software that I'm aware of right now that is able to look for a contrast enhanced strain. This was a study done by Dr. Lang's group, who I trained with in fellowship. He compared echo strain with and without contrast and to cardiac MRI, found similar measurements between the two, good agreement between, so there's some potential for echo contrast derived strain measurements. And keep an eye out for the results of the Succor trial. That's going to really impact our use of strain, and hopefully a strain-guided strategy in detecting subclinical cardiotoxicity will have great clinical impact in our cancer patients. So big picture, we have a lot of modalities that we can use in advanced imaging and cardio-oncology, not just echo and not just CMR, but PET scan has been looked at, nuclear imaging, cardiac CT. We can also look at their coronary arteries. There's still a lot of potential for these different modalities, but CMR across the board gets a lot of points for being able to check for a lot of different things all at once, and also very reproducible and accurate. So cardiac MRI, definitely an emerging role in cardio-oncology. Some lingering issues that I want to leave you with. Guidelines tend to focus on echo monitoring. In fact, if you look at like the recent ESMO paper, look at the ESC position paper, there's no mention of cardiac MRI, but the ASC 2014 guidelines do mention that if you are unable to get a accurate echo-derived ejection fraction or some discrepancy there, consider doing cardiac MRI, but I would probably go for the cardiac MRI before doing radionuclide angiography or a MUGA scan. So maybe that can be updated in the future, give some preference to cardiac MRI. Again, barriers to cardiac MRI shouldn't really be there. Yeah, it's not every center, but don't be worried about the length of the study or that you might have to give contrast to a patient with renal disease. You can get a non-contrast study that provides ejection fraction T1, T2, and strain imaging in 10 to 20 minutes. And also, that gadolinium contrast imaging may not be routinely necessary if you're just looking for ejection fraction. Also, a lot of our studies in MRI are just with anthracyclines and HER2 antagonists, and that's similar to echo studies. Do we extrapolate what we know about anthracyclines and HER2 antagonists to these other therapies? Hopefully, we'll in the future be able to see more studies dedicated specifically to like tyrosine kinase inhibitors, proteasome inhibitors, where I'm seeing a lot of cardiotoxicity from these. So definitely more room to find where to go from there. Again, lots and lots of potential complications from chemotherapy, a wide variety of potential disease cardiotoxicities, and it's tough to keep up with them, but hopefully we got a lot of smart people out there who can overcome this, and we can get some good data that can guide our treatment. So I'll end with that, And thank you all so much for your time and attention. Appreciate the questions from the audience. Thanks, Dan. And if you have any questions, feel free to email me, or I'm on Twitter as well. So thanks so much.
Totally fantastic, Jeremy. I really appreciate it. You had a lot of content in there, so I think that definitely MRI is an extremely important tool. I will say that the ESMO guidelines that came out in January, February this year basically said, you can do echo because it's available, obviously, but MRI would be the alternative choice. And we really didn't even speak much about MUGA at all. So I think that, that in terms of following EF, I think that those are the two tools. And depending on your availability, then, that's.
For sure. And I think before we start seeing talks about cardiac MRI as a biomarker, imaging biomarker in the guidelines in these position papers, I definitely think we still need some more data to confirm its utility.
Absolutely.
So, I think that MRI today is where echo was 15 years ago in the oncology world, and that I would venture to guess that the echo at some point will have the same resonance as MOGA with us today. This is the future.
Yeah, I would agree there. So hopefully we see more use of it going forward and more applications, because I definitely think it has amazing potential in impacting our treatment.
All right. Well, thank you so much. Really fantastic presentation, and had a lot of people listening in, and you really covered a lot of territory. So thank you so much.
Yeah, huge topic. So hopefully was able to give kind of an overview of where we can go from here. So, all right. Thanks, Dan, and thanks, Steve and everybody else. Yeah. Thanks a lot.
Thanks, Jeremy. Thanks for everybody being on.
Thanks, Jeremy. See you, everybody.
Thank you.